I would be very happy to hear that last topic. All right, great. So let me just start. What is the level of healthcare in India, and how much it is? Is it a growing area? It's a flat area? Anything from the audience? Yes, sir. Yeah, probably if you can pass on the mic.
I think we need to improve a lot, and especially when we talk about, from completing the payment system in public healthcare. So that is still, in very bad situation, and lot of things are happening. Like most of us often see, various incidences that happens at hospital, in private hospitals especially. So that is the major area that NHS should take forward, I think. Thank you.
Super. Thank you. So, just from a numbers perspective, probably India, the market for AI in healthcare currently is somewhere close to around $750 million today, which is expected to be around 7.5 to 8 billion in the next 8 to 10 years, around 40% CAGR year on year, right? So it's a huge area where a lot of things can be done, and that's something which we'll try to cover and also address your question, sir. So probably to start with, if Professor Gupta, if you could help us in understanding as to what and how in practice, in actual practice, AI is helping you as a professional, and what more you see that in the next few years, how AI is gonna maybe complement your work, or some people say substitute people. We've heard a lot of sessions actually. I'm sure you guys would have heard about substituting humans with AI. So what's your take on that, sir?
First of all, let me introduce. I work in Apollo Hospital. I think I'm audible perfectly?
Yes.
Okay, so I'm a clinical cardiologist, also an interventional cardiologist. Interventional cardiology means that I do intervention. Intervention means with the help of balloons and catheters, you are able to open the blockages or close the holes inside the heart, or you can do electrophysiology, which can also do something like pacemaker whenever it's required, or prevention of sudden cardiac death. These are the various, because I think it's being recorded, so a lot of people will listen later on. So I think should I give you the basics of what cardiology is doing all over the world. So interventional cardiology has become the more mainstay, and it is almost replacing surgery. Not completely, and many times the holes can be closed by non-surgical technique. So these interventions are non-surgical. That means we don't use knife, and we are using only some special device through which we, from the artery or from the vein of the groin, which is femoral artery, we introduce a catheter which goes into the heart through, of course, the system which God has made that you can always access the heart through any artery. So we choose normally a big artery, which is the groin artery. We can also go through the wrist artery, which is the radial artery, because finally you have to reach the heart, and without opening the chest. So this is interventional cardiology. A lot of people may not know. That's why I'm giving you a simple explanation of what is interventional cardiology. It's the first angioplasty, when it was done in 1977, the surgeons were only doing the open heart surgery or open chest surgery or bypass surgery. So since 1977, the first angioplasty was done by a German. He was a fellow working in Germany, and there was a huge applaud all over the world. And you will believe that America has always been like that. He was immediately bought, I would say, and a huge Andreas Group Center was made in America, and finally he was almost not deported, but he was something imported, and then he became American citizen. So Germany could not do anything, and finally he was working there. The first stent, which is a coronary stent. What is stent? Stent is a stainless steel structure. I think there's no harm in giving the basic and coming to artificial intelligence.
Sure.
So because it's a finally learning for everybody. So the coronary stent, earlier the blockage was only being removed from 1977 till 87 with the help of balloon. You put a balloon inside the catheter going from the groin, from the femoral artery going to the aorta, which is abdominal aorta, crossing and then reaching the coronary artery, which is a branch of the aorta. Putting the balloon across, inflating with the help of small pressure outside in a beating heart. So this was anybody who did the first time is actually the hero, because you cannot kill the patient on the table. You have to do something we have done on the animals first and then you. So from 1977 till 87 there was no stent. So the problem with this plain balloon angioplasty at that time was that there was a recurrence of 30%, and sometimes there was a dissection inside the artery leading to thrombus formation and immediate occlusion, which was not required but not desirable. So Dr. Ulrich Sigward, who is our friend from Switzerland, came up with the idea if we can put a hollow cylinder after putting the balloon, and then put the cylinder and leave it there, so that the valves are opposed and there should not be further recurrence, or there is no further recoil. To prevent the recoil, the stent was developed 1987. And that time there was a bare metal stent from 1987 to almost 2001. There was no medicated stent. Now you are using drug-eluting stents. The problem with the bare metal stent was there was a recurrence of about 10%. That means within 6 months, the stent is considered to be a foreign body by the body, and they start fibrosing inside. For example, if you get a scar, you have a healing system. The body will have a scar formation with a special fibrosis. You can see whenever you have cut or you do a surgery and then surgery, you will find a scar. The similar scar was being formed inside the coronary artery, and that was taken as another recurrence. That means again it was narrowed down, putting the hole and further narrowing. So that was the time the 10% patient will have it. So they came with the idea that we'll put a drug which will prevent fibrosis inside the stented area. And that was terolomas, which is actually chemotherapy. It's a sort of an anti-tumor drug which was coated onto the stent, and then drug-coated stent came, and the era from 2003 till 2025, most of the cases of angioplasty is being done with a medicated, or rather 100% medicated stent or drug-eluting stent. Drug-coated stent have the various names, which the proper name is drug-eluting, because the drug is eluting from the system, from the stainless steel. And let me tell you, the arteries and the stent are only 3 millimeter. So when you see on the angiographic film, many of you have seen it, you will see a very high, good size. Actually, it is a very magnified picture. So God has done a very injustice, I would say, here. First of all, He made only one heart, and our friend was talking with Abhinav that we have 2 hearts from the beginning, the two engine aircraft rather than single engine aircraft. So the one injustice was that only one heart, the 2 eyes, 2 kidneys, 2 parts of the brain, 2 legs, 2 hands. So but only one heart, because God wanted to keep in control the death. Because if you're too hard, the chances of death will be much less. So that was one injustice. Second injustice, what He has done, that arteries which are supplying the heart, which are known as coronary arteries, they are, I'm sorry for deviating from the topic because it's very important they come into the artificial intelligence. Sorry for taking your time. So the arteries which are there, which is supplying the heart, is only 3 millimeter diameter. 2.5, 3.5 is the maximum, 4 millimeter. So when the cholesterol develops there, with the cholesterol, the artery becomes almost 1 millimeter bore. And that 1 millimeter bore is supplying the most important part of the body, which is heart, and that is actually just between the survival, between the life and the death, is only 1 millimeter bore through which the blood is going. So that is the problem, that's why the patient can have sudden death, because 1 millimeter clot formation, patient will die instantaneously. So coming on to the part, now we are doing a lot of angioplasties and bypass surgeries and robotics, and also coming on to the part how artificial intelligence can really help us further improvise the healthcare in general or heart care, to be specific, because I am a cardiologist. So what we are doing today is ECG, because what ECG further can be improvised. There are various diagnostic systems through which we make a diagnosis of heart disease. First is basic and simple ECG. ECG today can only tell old heart attack or the present heart attack. It cannot tell future as of now. Because when I see the ECG, okay, how much blockage? I don't know. Because even 95% blockage will have a normal ECG today. So when I see ECG, the patient asks, what is it? I said, you don't have heart attack and you have no previous heart attack. That is the maximum I can tell you. Or we can also tell with the present ECG that you have some hypertrophy of the ventricular myocardium. That's all. We can also see the rhythm, but we cannot have future. So the futuristic part of AI. What is AI? I wanted to read a very interesting thing because I think for the basic people who are not educationalists here, a simple method. Artificial intelligence is the ability to make computer or machines. Artificial intelligence is the ability to make computer or machines learn to solve problems that would otherwise require human effort. Advances in computerized power have made it possible to analyze large amount of data. Data, very important, because you put the data and from that it analyzes quickly and consistently and accuracy. This has enabled the healthcare scientists to apply AI to huge complex data sets in a way that improve decision making, diagnosis, treatment by detecting patterns in the patient base. So when you put a billion of data, then the machine will make a diagnosis. Okay, this part of the ECG had in future about 10 years later had a heart attack. So they will see something which human eyes cannot see. So futuristic ECG will be that even with the present ECG put in the AI, you can say, okay, you may have a blockage of 80%, although today we cannot. Or you can have atrial fibrillation in the future. Or you can have some serious heart attacks, especially in the future. This is what AI can tell in the ECG. Coming to the second part, which is X-ray. What X-ray tells you? X-ray is a fluoroscopic machine. I'll take another 3 minutes and then we'll come back. So X-ray is a fluoroscopic machine which will tell you what is there in the chest. So everything is not fluoroscopic possible. The bones are the most densest. The heart is partly dense because the blood is there and the muscle and this. And the lungs are mostly transparent. That's why we see the lungs as black. The rest is the white. So when you see today in an X-ray, we can only say there is a fluid or there are no fluid. Of course, not more than 100 ml. If it is less than 150 ml of fluid, you will not be diagnosed by X-ray. Then you require echocardiography. Or you can see the size of the heart, which will be matching it. But future X-ray can also be verified, and it can tell you with less amount of fluid, or whether the lungs have the fluid or not, which cannot be confirmed today. The rest, I think, I'll take the second part, how the cath lab will work, because I think the other people will speak, and then I come back to you. So, how the cath lab, angioplasties can be done in future, how we can do further AI to use, prevent, and treat also, more specifically. I think I can take up the echo and cath lab part in the second part of my talk.
Sure. Thank you so much, Professor Gupta. Dr. Gandhi, I know when we were speaking, and you have been investing in healthcare